Good afternoon, everybody, and welcome to this special research presentation this afternoon. Our guest is Dr. Steve Scheinkoff, who is a professor of pediatrics at the University of Missouri. Steve got his undergraduate work at Tufts University and then saw the light and came south to the University of Miami, where he did his graduate work, receiving his PhD in clinical psychology in 1999. And I'm sure you partied like it was 1999 when you finished. He went on internship at Brown University, stayed on as a fellow, and became faculty member there, where he spent a good part of his career so far as assistant professor and associate professor. And then 3 years ago, moved to the University of Missouri, where he's been as directing a center on autism and developmental disorders, or I think that's what it was called. And we're delighted to spend some time with him today. And he's going to give a talk on novel and scalable methods for studying the emergence of autism in general pediatric and enriched risk cohorts. Steve?
Great. Well, it's really great to be back here. Very nostalgic to come back to a building. That's all. It all sort of comes back to you when you roam the hallways. So it's really good to be here. Just to start, just some.
Check. Yeah.
Do you use the mouse or no?
Yeah, no. It's just you have to actually choose it and then boom.
Yeah, now we're business. Okay. Disclosures. So we have NIH support. Some of what I'll talk about here does have associations with some patented work. So those are the disclosures. What I want to talk about, I have various studies on and related to autism and neurodevelopment, and also related work outside of autism as well. But I want to focus this talk primarily, for the most part, on thinking about infancy and how we might think about autism in these early developmental periods. So we can think of autism as a syndrome in the traditional sense, a collection of symptoms that defines the condition by that collection of symptoms. But it's one, as many in the room and online know, that is typically, not typically diagnosed until 2 to 3 years of age, and especially when you get below 12 months of age, we're thinking really of prodromal indicators or features that might presage the later diagnosis. But we're really not making diagnoses of autism at those ages. And I think of autism actually as an outcome in that sense, as something that doesn't exist in the way we define it later on in earlier infancy. So everything we're looking at is kind of prodromal. And when I think about the prodromal period and early identification, we can think of, well, why, what are the opportunities and challenges associated with studying this condition in these early developmental periods. So we can think of autism as an emergent syndrome, something that develops and unfolds over time. And that probably has something to do with developmental cascades that help explain the emergence of these symptoms. And I find this actually intellectually quite fascinating. How can we have a condition that can really blossom, if you will, and emerge in distinct ways, and by the 3rd year of life, sometimes with great deals of impairment, sometimes not, but very distinctively, yet be so subtle early on. And I find that just a fascinating scientific problem. But that subtlety, I think, offers both challenges in terms of what we might design for measurements to identify early indicators, but great opportunities, because here's a time where children's developmental path has not diverged as far from the typical course as it will have later, and therefore might offer opportunities to support children's development, positive outcomes in a way that might be less possible later on. And in a broad sense, we can make use and capitalize on these periods of tremendous brain plasticity in these early months of life. And so we want to think about how to support positive developmental cascades so that we can limit later disability and improve functional outcomes. And that's sort of broad scopes. I'm going to be talking not about treatments, though, today, and more about some novel ways that we might be able to uncover early indicators. So there are various strategies for studying autism in infancy. Some of them have been used, of course, here at the University of Miami. Infant sibling studies, of course, have I just look at Dr. Messinger here in the audience, and of course, you guys are part of the Infant Siblings Consortium, and in that consortium, that's been used to show that there's an increased recurrence rate of autism in younger siblings of full siblings of autism. Somewhere 18 or 20% of those infants will go on to have autism. If you look at more population-based studies of recurrence rates, it's a little lower. So it may depend on, that might be impacted in terms of how you're ascertaining kids at these outcome rates, but that's quite a bit higher than the overall general population prevalence of autism, which might be in the 1 to 2% depending on whether you're looking at US studies versus global studies. We can also look at other enriched risk or enriched likelihood cohorts, such as premature infants, and there seems to be a dose-response relationship in some ways between degree of prematurity and likelihood of autism, with extremely premature babies having somewhere in the 7% range of autism outcomes. And so that's another, and I'll show you some data from a preemie outcome study that I've been affiliated with as well. And then I think moving forward, there may be opportunities to look at specific genetic conditions that may be related to later autism outcomes as genetic testing changes and we begin to uncover in earlier infancy genetic differences that right now are probably going to be uncovered later in development, but there may be opportunities there. And some of the work that I'll talk about today is related to this fourth method, which is the brute force method of looking at autism outcomes in general population studies and trying to problem solve tools that give us some depth of information and signal that might be related to later autism outcomes, but feasible to deploy with large numbers of infants. And that's a challenge. Just want to spend a couple of slides just to orient you to some of the context, both in terms of studies and methods that I'll describe here. And so some of the studies that have some of the data that I'll present come from these 3 studies, and there are a couple of others I'll throw in there as well. So some of this data will come from the maternal lifestyle study, of which Miami was one of the study sites. And this was a cohort that was built beginning in the early to mid 1990s. I'm going to say the first birth years were probably 93-ish, circa, something like that. And this was a study of prenatal exposure to cocaine and or opiates with a non-exposed comparison group. And ultimately, there were nearly 1,400 infants followed from birth through middle adolescence. This is not an autism study, but it was large enough to capture individuals who ended up having autism. And so we were able to identify 12 to 13 infants, confirm diagnoses later. And I'll show you some data related to them. A current study that's active currently is a study that was part of the ECHO, National ECHO Early Childhood Health and Outcomes study out of the NIH Director's Office. And these linked up cohorts. This is sort of a cohort of cohorts study. So it linked up cohorts nationally that had early infant or prenatal data and looked to harmonize data for with common data elements moving through development. So this particular ECHO cohort was part of the NOVI research network, which looks at follows premature infants, and so this was a collection of NOVI network research sites that followed babies born 30 weeks gestational age or younger out into now they are probably 9 or 10 years of age in this particular study. So I'll show you some data from that. And then a current study that is currently active is our R01 funded study of a general birth cohort that has 2 names to it, the Rhode Island Neurobehavioral Observation Study, or RHINOS, and the earlier study, which is the Missouri site of that study. And that's a study of general births in Rhode Island and in Missouri and central Missouri. I'll talk about a few different measures and methodologies, but just a couple just to highlight one or two slides using a measure of respiratory sinus arrhythmia, so a measure of autonomic functioning thought to index and reflect infants or young children's growing ability to regulate their state, emotion regulation, and state regulation in the face of environmental demands. And this can be done using pretty standard EKG methods and allows us to get variation in heart rate variability in time with respiration, and is done to index this autonomic regulatory function. I'll spend some time talking about cry analysis as a measure of neurobehavioral integrity and arousal and response in infants in relation to developmental outcomes. And one or two slides on a more focused neurobehavioral exam called the NICU neurobehavioral scales, which is an observational exam that was used in a maternal lifestyle study and that we intended to use in the Rhinos earlier study. And I'll get into some of the story of that, and that's in part a COVID-related story. Because the cry analysis is probably relatively new to people, I wanted to spend a little time sort of telling you about how we do this. And this is really a signal detection sort of problem. So all babies cry. That's what they do. They do it well. And when they cry, they produce often highly sort of stereotyped types of utterances that have, especially if it's a pain cry, often has when babies are in pain or respond to a painful stimulus, they may have an initial long utterance. In technical terms, it would be a wow, right? And then they sort of settle into more rhythmic, reduplicated, repeated crying. And this top of the slide gives you a visual representation of a cry. In the y-axis is the frequency domain. So this here ranges anywhere from 500 hertz or cycles per second up to 8 kilohertz or 8,000 cycles per second in this particular view. And then in the x-axis is time. And if my pointer will work, you can see this first area where there's a lot of red information is an utterance, a time where a baby is producing the crying sound by forcing lots of air out of his or her vocal tract, and it's vibrating the vocal folds. And that vibration of the vocal folds, when it's unobstructed and clear, is going to produce what you and I would describe as pitch, and what in acoustic engineering terms we would call the fundamental or base frequency of the cry. And so this base frequency can be seen in these sort of dark lines at the low level of this utterance. And then the baby falls into a series of shorter utterances after that. And we can measure a bunch of things from that. We can look at this visually and describe where pitch is. We can describe where pitch may be exceptionally high. We call that hyperpitch. We can describe where the signal is really clear and where you can see densities in the acoustic signal and make out the fundamental frequency clearly. And we'll call that, just in our terminology, we'll call that phonated or voiced utterances. And we can see areas where there's probably some obstruction or tension in the vocal tract that's not allowing the vocal folds to vibrate at a regular rate. So it's messier. And you can see that in this image here, this part of the image here, where you really can't find the fundamental frequency. It's not.
We can't see though. So I assume the Zoom people can't do that. We can't see what you're indicating.
Oh, okay. well,
Yeah, I'm not saying you shouldn't.
Yeah, but thank you for the pointing out. So I'll no longer point in the Zoom. So, but that first utterance where it says dysphonation in the top, you can see there's a lot of messy redness, and you can't make out sort of a bottom solid line, if you will. So you can't really pick that out. So we can look visually at these things, but that's not particularly useful for large scale research and for quantitative analyses. So some years ago, colleagues of mine and I wrote a federally funded grant where we combined expertise in infant crying, infant development with sound engineers to develop an automated acoustic analysis tool. This just gives a visual representation of what we're doing. We're applying signal detection processing methods to digital audio files, and we are pulling out in fine-grained detailed acoustic data, quantifiable acoustic data that's dumped into a series of comma-separated files. So it's files you can open up in Excel or whatever statistical tool that you wanted to open up in. And so these become really powerful because instead of spending, a long time looking at one cry file, I can point this at a set of 100 audio recordings and get a data set in a couple of minutes, which is great. And we did careful work to validate this so that when the computer is tracking the fundamental frequency or the pitch, it's doing so at a rate of 12.5 millisecond blocks. So every 12.5 milliseconds, it's giving us an estimate of the fundamental frequency. And we had some undergraduates who, God bless them, looked at the very detailed variation at the sort of bumpy level of the data and manually calculated pitch for thousands of sort of pitch cycles. And then we did some signal detection processing to clarify and confirm that our analyzer was doing that accurately, basically. So a tedious but necessary step. So that tool is now, allows us to have good throughput when we have a bunch of cry samples. The NICU neurobehavioral scale that I mentioned earlier is a relatively brief now neurobehavioral observational exam developed for the maternal lifestyle study as part of their network effort with NICHD. It's sort of a variation of the Brazelton scales that allows for some quantifiable profile scores that measure motor functioning, state regulation, arousal responses, attentional responses, et cetera. And so I'll show you a couple of slides that look at data from that as well. Let me just start to get into some data and results that we've used to think about what might be different about individuals who go on, kids who go on to a later diagnosis of autism, even in the early infant period. There's a lot of work that I'm not going to summarize, some of which is done here in Miami, looking at social responses during standardized observations in the early to middle infancy period. So that's really important work. We also wanted to look at alternative ways of measuring arousal, attention, and state regulation in babies across this period of time as well. In the maternal lifestyle study, which is the left-hand panel that you're seeing, we measured heart rate variability, respiratory sinus arrhythmia, from 1 month corrected age all the way through middle childhood. And what we did with this study was we said, first of all, I mentioned that we identified some individuals with autism in this sample, and we traced around the country to various study sites and confirmed diagnoses with standard clinical methods, autism diagnostic observation schedules, record review, interviews with parents, sort of best estimate clinical diagnoses. And so we were able to identify 12 to 13 infants. The 13th is a little murky with confirmed autism, and then looked back at what data we had available for them and selected comparison infants from the larger maternal lifestyle studies source database. This left-hand side is a latent growth curve analysis that's a little faint in your view, but I'll describe what it's showing. What it's showing is that from birth or 1 month of age out to age 6, we're finding that there's a growth curve for respiratory sinus arrhythmia that increases across the first 3 years of life, and it's approaching more what we think of our adult levels of the magnitude of this heart rate variability by age 5 to 6 years of age, and that is consistent with other published data from typically developing samples. And so we had this sort of elevated this curve. We recreated that growth curve for our infants with autism as well, and it was flatter, so there's significant differences in both the shape and the linear and quadratic difference in this term. So there's a shallower growth, and the difference between the infants with autism and the quote unquote more typically developing infants really showed up in the sort of the 18 to for 18-month to 48-month age range. So this is one way we can begin to see that there's sort of different growth and functioning and autonomic regulation across development. This is just a methodological example. Interestingly, a few years earlier than this publication, there was another publication that looked at heart rate variability in another group of babies, not with autism, but with variation in, I believe it was social responsiveness scores, scale scores. And so they found that babies that had elevated sort of likelihood or differences that were autism related also had a flatter, shallower growth of RSA in that sample as compared to babies who had more typical range scores. So that was actually a sort of validation across different samples of replication in a sense. But I want to get into the vocalization work a little bit. I didn't have this slide in here initially, but I thought I should put it in because one, I want to talk about just briefly that we know for autism that vocalizations are often atypical. That used to be part of formal diagnostic criteria, especially in the DSM-3R, so early versions of the DSM. It pops up in measurements such as the ADOS and the ADI, and it was talked about early on by Leo Kanner when he first described the condition in terms of variation in vocal quality, we'll call it. Many, many moons ago, here in this building, I collaborated with Kim Aller and others to look at atypical vocalizations and canonical babbling, so lull form babbling, in preverbal kids with autism. And the thought originally was we were going to uncover some differences in rates of articulation of syllabic type utterances, even in preverbal kids with autism compared to children with what we would now describe as intellectual disability. And so some of the babies, some of the young kids, these are 3 to 4-year-olds or so, came from, a few came from Debbie School, some came from Easter Seals, which is my memory holds us across the way here, in various places. And I think another school up at Nova, Southeastern. And so we recruited those infants, and we did not find a difference in those children, I should say, in terms of the rate of well-formed babbling, at least on a group level. Although, if you look on the right-hand panel, what we did find is that the distribution seemed unusual. So there are some kids with autism who had a really high number of well-formed canonical babbles, and many others had low rates. And so there may be some subgroups lurking in here that obscure some mean differences. What we did find in terms of mean differences was that the children who had autism compared to the intellectual disability comparison group were producing vocalizations that were what we framed as atypical in all sorts of ways. Growls, yells, squeals that were unconventional ways of producing sounds, maybe the best way to put it. And we could quantify that. And that was a useful publication in terms of sort of demonstrating that this can be observed in a reliable fashion, and help us think through that, there may be some atypical vocalizations, even in the preverbal stage, that we can think about. A lot of this has to do with prosody, intonation, and voicing. And when we think about cries, it's really all about intonation and voicing. And babies produce these sounds from minute one, right? So this is those change developmentally as the baby's vocal tract is changing and growing, but it's a signal that we can measure at the earliest moments of life that might help us understand the emergence of these sort of individual differences. So we did a few things as some initial looks at this. The first thing we did was collaborate with Janet Iverson at the University of Pittsburgh to extract cry vocalizations in 6-month-old infants with elevated likelihood of autism, so infant siblings of kids with autism, subject those to an earlier version of a cry analysis tool that we were using at the time, and found that the infants who are at risk or at likelihood for later diagnoses had cries that were pain-related cries that were higher in pitch and more variable in pitch. So that was one sort of initial finding. What we did next was begin to look at data from the maternal lifestyle study, because all those infants at 1 month corrected age had the NICU network neurobehavioral scales administered, and then immediately after the NICU networkers or the NENS was administered, babies were administered a cry stimulus. So this was a mildly painful stimulus, a flick to the bottom of the foot with a standardized instrument. Daniel, you may remember the instrument. It looked like a little macrame device.
I'm afraid I do.
Yes. I'm not sure we'll get through IRB today, but we did it. And that produced 30 seconds of crying that was recorded and then subjected to acoustic analysis. The first thing we did, though, was actually look at how people were perceiving and responding to these cries. So this was a really fun project to do because it was an undergraduate honors thesis, which was wonderful. I mean, it was Sam English was the primary author in that. She did this as part of her senior honors thesis, where she ran a cry perception study with me, where we asked parents of children, parents who had kids in the younger age range, so under age 5, both with and without autism, and we had them listen to the cries from the maternal lifestyle study that were produced by kids with autism and a comparison group without autism. And all they knew was they were going to listen to cries, and we had a set of questions, about 7 or 8 questions that they asked, that they responded to on a Likert scale basis. And what we found is that the parents of kids with typical development and the parents of children with kids with autism, they responded to these cries in a similar way. So these TDAs you refer to as parent groups. There's really no difference there. But we did find crossing with sort of within and across both groups is that when parents listen to the cries of babies who later had diagnoses of autism, where the cries were recorded at 1 month corrected age, really early, the cries of the later diagnosed children were described by these parents as being less typical, more distressed, and in greater pain than the cries of the babies who had more typical development. And so if there's something that we can hear differently, something differently acoustically as well. So we began to look at that acoustically by subjecting those cries to our newer acoustic tool and combining that with the NICU neurobehavioral scales as well. So these data show basically what I already told you. We had almost 1,400 babies. We had 19 babies with suspected autism, meaning that they studied site coordinators at each of the MLS sites said, this parent may have a child with autism, maybe not. It wasn't really designed as an autism study, so we really had to do some sleuthing that out. 13 cases with autism, 8 where there was a successful cry recording. And we subjected those 8 compared to a larger comparison group to a logistic regression method. And we did a couple of different logistic regression models. This one is combining the cry variables, which has to do some of the cry variables have to do with timing of the cry, how long are utterances, what are the intervals between utterances. Some of them have to do with things related to pitch and voicing, and some have to do with loudness or energy, but not overall loudness as much as amount of acoustic signal in various sort of acoustic dimension bins, if you will. And what we found is this collection of acoustic variables was predictive of later autism diagnoses, even when accounting for some basic potential confounding variables. And factors that we pulled out of the ends having to do especially with arousal, excitability, state regulation also were predictive of autism. Small sample, right? These are pilot data from only 8 babies. So this is sort of proof of principle that there may be signal here that we can look at. We went a little further and say, well, let's imagine we have a bigger sample and let's try to plan for sample size. So we did some bootstrapping of these data to determine what this might look like in a larger model. Again, bootstrapping is a kind of made up data, right? But done in a way that helps us with proof of principle to justify future studies. So when we enter just covariates, demographics, APGAR scores, we don't get much of a prediction. And you get a really wide confidence interval. When we add in cry, we get a really good area under the curves, 0.95, and we simulated, or bootstrap data, I should say. And interestingly, when we add the ends in, it really doesn't change the prediction all that much. There's a little bit, there's not that much variation. So, but this was an early indicator that we thought is preliminary data to justify looking further at cry and neurobehavioral status in babies. I'm going to come back to this in a second. I want to just talk about this other study I mentioned earlier, which is our preemie outcome study. This is the Echo Novi study. So just as a reminder, these are babies who are born 30 weeks gestational age or younger, who often have a rather complicated medical course, and come from a variety of sites. So that's the study sites included Brown University, Michigan State University, Children's Mercy Hospital in Kansas City, UCLA Harbor, and Hawaii. And I repeatedly volunteered to go to Hawaii to do a study visit. They don't let me, but someday. And so in this initial study, which was done by a postdoc, Coral Schuster, we began to look at neurobehavioral profiles in the context of medical complexity, predicting autism screening outcomes at age 2. And that was 2 years of corrected age, I believe. And so what we find is both these together and independently are predicting positive MCHAT screening results. And so medical complexity was basically a cumulative index of things like retinopathy of prematurity, significant infections or sepsis, et cetera, brain bleeds, things of that nature that went into a score, predicted these outcomes. And a particular profile from the end, so they're making neurobehavioral scales that described infants who are, for lack of a better term, really dysregulated in terms of their response to the presses on that exam, also were predictive of this later outcome. We also began to look at cry. So we recorded cry in this study as well. Cry was recorded differently than in the study I told you about before because it wasn't a pain-elicited cry. We extracted cry recordings out of the ENDS exam. So for every ENDS exam done in a standardized pram with a standardized recording apparatus sort of attached to the side of the pram at a similar distance between from the baby's mouth, so we could get some good, relatively standardized high-quality recordings. At some point during the ENDS, we want to see how babies self-soothe a little bit. So babies are left to cry briefly, and then there's a soothing package where the examiner will start to do some procedures to see how much sort of intervention from the examiner is needed to bring the babies back to a sort of a more calm state. But that gives us a chance to get a relatively standardized, not pain-elicited cry, but elicited by exam kind of cry. So we did that. We extracted those cries from a whole bunch of these ENDS exams, subjected them to our analysis program. We have in this analysis, which was done by another postdoc, Andrew Magnault, looked at categorical Bailey scale outcomes, categorical child behavioral checklist outcomes, and categorical autism MCHAT screener outcomes. And over 14,000 utterances were analyzed, and they were analyzed in a random forest machine learning model, and with sort of careful attention to how we selected the variables. We got a lot of variables out of the cry sample, so we used an empirical data-driven way to select the potential predictors for final models, and in a way that we hoped would be less biased than just picking and choosing on our own. What did this show? So in these series of predictive models, we found, and I think this is remarkable in this very messy sample, right? This is a sample where these infants, because they're extremely premature, they have a whole range of heterogeneous outcomes. And so the cry variables were predictive of problems on the CBCL, presence or absence of delays in language, cognitive, and motor scores, and positive MCHAT outcomes as well. We don't have autism outcomes in these infants yet, so that is hopefully going to come as we figure out a way to problem solve on that. This was a COVID-related delay and now a gap in funding to do that. So we'll have to, we're really needing to problem solve on the actual autism outcomes. And then finally, I'm going to tell you about this other R01 funded study that we have that was in part built off of the preliminary data that I showed you earlier with those bootstrap data that helped us articulate what we might see in larger samples of infants and looking at cries. So this was part of a call for applications looking at indicators of autism in the first year of life from NIMH. And we were fortunate enough to get funding from that call. Couple of things I want to tell you about. One is this was intended to be a general birth cohort. And when we started it, I was still at Brown University at Women and Infants Hospital of Rhode Island specifically, which is a really interesting place because although Rhode Island is a little corner of the world, like 1.1 million people, I think, in the state, with some surrounding areas of Massachusetts and Connecticut that are part of the catchment area. Women and Infants has one of the larger obstetric services in the country and has 8,000 to 9,000 births per year reliably. And is basically a population sample of Rhode Island. 80 to 85% of births in Rhode Island happen at this hospital. And so that allows us to really think on a population basis about sampling, which is really, and it's research friendly. So it's a really interesting place to do work. We partnered with an institute called the Hassenfeld Child Health Innovation Institute that was building a birth cohort that I was involved with as well before this grant became funded. And so we really intended to build this on the birth cohort that was being built by the Hassenfeld Institute. And the initial plan was to do newborn assessments in the newborn nursery. So we had a whole range of staff roaming the hallways of Women and Infants Hospital, recruiting patients. And the idea was they would go into the hospital, recruit the patients, do some pretty quick surveys because we're looking to have a large throughput, do the NICU neurobehavioral scales in the hospital in the neonatal period, during which we'd record cry. And then we'd enter children into relatively low touch follow-up using survey tools that we think would be quite scalable. And specifically, we use this survey of well-being in young children, which is a really nice platform for developmental surveillance that comes out of Tufts New England Medical Center. And then start to see the children in person at 12, 24, and 36 months. We were all ready to go. We piloted our measures. We were set to enroll our first patient sometime around the Ides of March of 2020. And things shut down 4 or 5 days before that. So we had to completely re-engineer this study. Some of the things we did was try to see, well, can we get back into the hospital? We really couldn't. Things changed so much pre and post COVID. One is that we kept on getting these sort of, as you know, well, these sort of waves of infection. And so restrictions in terms of what we could do in a hospital sort of waxed and waned, and that made sort of long-term viability of that method or approach just didn't seem feasible to us. And even when restrictions were loosened, parents were being discharged much more quickly than they had in the past. So there's not a lot of time to do what we needed to do. So because the patients primarily need medical care, so there's all this stuff happening in the rooms in this compressed time point. There's no way we were going to be able to get in and do these sort of exams and parents didn't want us hanging over their babies, breathing closely on them, things like that. So working with NIH, we made the difficult decision to put aside the NICU neurobehavioral scales and re-engineer the cry analysis, which they were especially interested in, by moving to a remote collection method. So we still roam the hallways with women and infants, but basically to sort of parachute into patient rooms quickly, do consent and recruitment, give them links to, we would do an initial survey, either right there in the room if we could, or by phone within a week or two. And then the second they signed up for the study, they were given an ecological momentary assessment tool on their telephone. And so these are tools for remote delivery of surveys that can be done briefly in the course of everyday life, used pretty widely in psychiatry these days. We found a company that would allow us to have as one of the survey questions, record your baby's cry. So as soon as parents sign up for the study, they download this on their phone, we log in the date of birth and clock starts ticking so that at about 3 weeks of life, they start to get pinged on a weekly basis that today's your day to record your baby's cry, with some basic directions about how to do that in terms of how do you point the microphone to the baby's mouth, how far away should it be, time of day, babies might be fussier in the early evening, that might be a great time to do it. They are, question one is record your baby's cry, they push record. We seek 30 to 60 seconds of crying. The infants, they then stop record, they can listen to it. If dad said something embarrassing on recording, they could try again. So they have full control over what they share with us. And then they can upload the cry to the platform that we use. And as soon as that gets uploaded to the system, it triggers a series of questions that help us get a sense of what the setting was when the baby was crying. Why did the parent think their baby was crying? How typical or atypical of their baby did they think that cry was? What position were they in? Things like that. And they get several opportunities to do this crying. And then they enter into our low intensity observations or surveys using the SWIC and some other measures. And so we use the survey of well-being in young children at 3, 6, 9, 12, and 24 months of age. And this gets measures of developmental milestones, as well as more sort of infant behavior temperament measures as well, including sleep. And those are scored. At 12 months of age, there are additional surveys that are used. So we'll add in the first year inventory, which is a emerging paper and pencil measure of autism likelihood that comes out of North Carolina. And there's a brief version of this called the FYI Lite that we use. And that gives both continuous and categorical scores. And also in the first year of life, parents are filling out the BAPQ, so a measure of subclinical autism features in parents. So we get a sense of parent characteristics that might be related to genetic risk of autism. And we're asking questions about family history of autism and other conditions as well. So I'll show you just some emerging data. So we recently stopped new recruitment to the study. We have consented a little over 2,200 babies in the study. That includes infants from Women and Infants Hospital, as well as infants from University of Missouri Healthcare System, and a smaller number of infants who are at elevated likelihood for autism from the SPARK research match. Although really we're focused on a general cohort here. Our initial analyses are not with a cry. We're just digging into that now. We have a substantial number of cries available to have that. I'll have that in a future slide. But we do have survey data from especially 9 and 12 and 24 months of age. This is a paper that was just accepted to Pediatric research in the last week or two. Aaron Andres, who's a F32 funded postdoc in my lab, spearheaded this, and we are looking at for the prediction of first year inventory scores at 12 months, sort of emerging indicators of autism, not a diagnosis, but just emerging indicators at 12 months, as predicted from behaviors at 9 months, and also related to temperament-related behaviors measured contemporaneously at 12 months. And so what we find is that that developmental milestones and temperament-like measures at 9 months are predicting social communication and sensory regulatory outcomes, so to speak, sort of intermediate outcomes in this study at 12 months. And the unique predictions seem to be a little different depending on the outcomes. So what in the SWIC world is called difficult temperament kind of measures are predicting individual differences or problematic sort of increased problems in social communication behaviors as reported by parents at 12 months, whereas 9-month measures of adaptability and difficult temperament are also predictive, but are predicting sensory regulatory concerns. And there seems to be some signal with sleep differences as well that we're exploring, but we're just in the early exploration of that. And this is, so that's our measure at 9 to 12 months. We have new analyses in the works looking at 12 to 24-month outcomes. With 24 months, we have 2 measures of outcome. One is the MCHAT, and the other is the CSBS, Communication Symbolic Behavior Scales Infant Parent Checklist. And so these are 2 measures of emerging autism or autism-related difficulties. And in this analysis, you can see that the FYI light at 12 months of age is predicting higher MCHAT scores, and in particular, the social communication difficulties as indexed by the FYI light is predicting higher MCHAT scores. These aren't categorical outcomes here. This is continuous measures in this analysis. And for the CSBS, it's social communication milestones also predicting more problematic or lower skills as measured by the CSBS. And we included demographic variables to begin to think about what our variation in terms of race, ethnicity, socioeconomic status might look like when we enter these sort of data. So in this measure, they were used really as a control variable, right? But we don't want to overly control away something that can be quite informative in terms of how measures reported by parents might be interacting with differences in culture, language, access to services, et cetera, that might be important. So we're exploring other methods to look at this. So this is more of a public health methodology, perhaps, or epidemiological methodology, where we're looking at a way to gauge whether there's some interactions between our predictor, in this case, FYI light scores, and in this analysis, the outcome is MCHAT positive outcomes. And the potential modifier here is minority status. So here we've dichotomized both our predictor and our outcome. So we have a series of 2x2 tables. And we're looking for, I think, what epidemiologists might call effect modification. And so we see some hints at effect modification for minority status in the prediction of MCHAT positive outcomes, such that in non-minorities, if you have a elevated FYI light score, there's a good prediction of positive MCHAT scores. There's still a prediction of positive MCHAT scores from elevated FYI light scores in the minority group, but it's less strong. And so there seems to be some sort of interaction there. We're cautious about this. As you can see in the table on the left, the confidence intervals are pretty big here still. And part of that has to do with this is beginning stages with kids still growing up through our cohort, and some of the cell sizes are on the small side. And so we'll have to be looking to see how stable these sort of patterns are as we collect additional data. We can't look at this quite yet for the CSBS just because the cell sizes are just way too small to do that, but we'll sort of do that as we get more data coming in. But this is an interesting additional method that we can help think about and unpack the potential influence of demographic variables. And here's minority status. We're also doing some embarking on some mapping so that we can map zip code, for example, to neighborhood or zip code related variables to get a sense of maybe some more structural things that might be happening that might be related to these outcomes.
Yes.
And final sort of data slide is an interesting analysis that we're just starting that's looking at developmental patterns of milestone attainment in infants where there's one or two things happening. One, and this is the middle sort of chart here, we categorized babies in this study as having either a high or a low FYI light score, so high meaning elevated indicators of autism, and categorize their moms as either having a high or a low BAPQ score, meaning either presence or absence of subclinical features related to autism presentation. And so you can have some dyads where both are elevated, either or are elevated, or dyads where neither are elevated. This on the left-hand panel are average scores on the milestone section of the SWEC at 6, 9, and 12 months. And you can see the basic story here is that infants where both mom and infant have elevated scores are lowest across the board on their developmental milestone scores, whereas infants who have neither elevated scores are highest on the milestone scores. And the mixed group seems sort of somewhere in between, but by 12 months, what we see is that if the baby has elevated FYI scores, they're lower in developmental milestones. If babies don't have an elevated FYI score, regardless of how mothers respond to the BAPQ, they have higher developmental milestones. And then we began to unpack item level data, and we just, for this initial analysis, and these are not statistical analyses, these are really descriptive views. We pulled out some variables that we thought just on face value had, face validity value had some relationship to emerging social communication in the dyad. And so we have making sounds like box, babbling, responding to the child's name, the child responding to his or her name, looking at their caregiver when upset, copying sounds the caregiver makes, or playing games like people. So these are parent reported reports at 6, 9, and 12 months of age. And the lines are a little hard to interpret, so I'm just going to tell you how to interpret them. And so basically what this is showing is that, especially about 12 months, similar to the group data, or the overall average data, infants who have elevations in FYI scores, including those without maternal elevated score, are showing lower level attainment of babbling, responding to name, looking at a caregiver, all these measures. Interestingly, we'll see how this unfolds, but you can see here in this middle panel, the babies who have elevated FYI scores are showing sort of an initial increase in response to the name, and then by 12 months the rate is lower, which we'll see if that sort of signal holds as we collect more data, but that might be consistent with some data that have come out of the infant siblings network showing decrements. The cries we're looking at now, and we have, so far we've curated these cries, meaning we've had research assistants who go through all of our recordings, make sure we know quality control indicators, things like that. So that takes some time. The actual acoustic analysis takes no time, but we have nearly 3,000 cry recordings curated from a little over 1,000 babies, and we're working through the rest. So how to think about this stuff? I know I'm a little short on time, so I'm going to run through this quickly, but when we think of moving from the prodrome to the syndrome, we think about what opportunities there are to intervene in this very early period of development. It might change our talking about things from treatment to prevention, but helps us, actually prompts us to think about what are we preventing, right? So just like I think in autism, the move has been for a long time, moving away from talking about cures, which raise expectations unfairly for parents. It's just not realistic. And so we're probably not going to be thinking about prevention of autism as much as prevention of disability associated with autism, supporting positive outcomes for children as they move through development. And there are, I think, a lot of really exciting opportunities. So we think that early treatment for autism is more effective than later treatment, although data are actually a little hard to come by on that because there are really tricky biases that you need to overcome in the data collection on this. And so that, I think that's a challenge research-wise. One of them being theoretically more severely affected kids are going to be detected earlier and then entered into treatment earlier. And so there's some tricky things to disentangle there. But there are opportunities to link research such as what I presented here in the future to emerging treatment options, especially at right now 10 to 12 months of age at the youngest. But one of the ethical things that we think of would be, if we're going to screen in infancy, we got to be able to do something for parents and families where there ends up being a positive screen. So thinking that through, but these sort of methods offer opportunities to support those sort of treatment trials as well, because if we're successful, we may be able to stratify groups of infants into more homogeneous samples that may potentially increase the statistical power of those trials as well. So I think there can be a real positive two-way street for these sort of studies. So in the future, we want to build on this emerging evidence. We want to be sensitive to ethical challenges related to early screening. We want to think through carefully what are the targets of treatment, and to the extent that these studies might uncover differences in arousal regulation and state regulation, think through whether or not there may be some novel targets of treatment that we can think about, in addition to the more traditional social communication, social relatedness sort of targets that we also want to tackle. And just a broad reminder for myself that as we think about general population studies, we need to think carefully about the wants, needs, values, the communities we serve. And when I put communities in here, I was thinking really broadly about communities, race, ethnicity, demographic sort of communities, but also from the autism point of view, we think about family communities, patient communities, who's speaking for whom, and really being sensitive to those dynamics. And I think I have a couple slides left, so if you'll humor me for a couple minutes, if we're okay time-wise. I wanted to just step away from the infancy period, as long as I was talking about communities, just to give you a sense of how I think about engagement with communities around research. So when I was in Rhode Island, and I'll tell you a little bit about Rhode Island, a little bit of Rhode Island, and a little bit about Missouri. When I was in Rhode Island, colleagues of mine and I built a statewide research registry consortium of sorts called the Rhode Island Consortium for Autism Research and Treatment, funded by the Simons Foundation and supported by internal funding at Brown University as well. And this was really, we brought together lots of different people to support this work. Clinicians from multiple disciplines, from multiple hospitals within the Brown system, but also from community providers. Parents of kids with autism, both those who were connected to formal programs and those not. We had parents of kids with autism who were funded on the project, and that really helped oftentimes hold our feet to the fire in terms of how we communicated and thought about interacting with the community. And we had adults with autism as part of this as well. And so we had lots of people sometimes arguing around a very big table and developing the basics of a statewide patient registry that helped give us a baseline for recruitment into research studies, but also some data that we could publish on. In a little under 6 years, we recruited 1,800 individuals with autism across the age range. Youngest was a little under 2. The oldest was age 70 or so. We had one participant who was close to 70 who actually had been diagnosed as a young child at Johns Hopkins, which got us thinking about who this older gentleman maybe interact with when he's younger. Could have been Leo Kinner, we don't know, but that was really interesting to think about. Most of the individuals were in the childhood to young adult age range, but we had some older individuals as well. And so we had breadth of sampling. And the little map here just shows the dots of all the people we mapped to the study. And that mapping also allowed us to think about how deep did we sample? what proportion of people with autism that we think were in Rhode Island did we ascertain? And we did, this was harder to think about for adults. So we really looked in the 3 to 18-year age range at what percentage of the autism community we thought we may have ascertained. So we did this by mapping everybody to a census block and then pulling information from that census block about the number of individuals in different age strata, and making assumptions about what these sort of available, I don't know if this is the right term, but available prevalence in that age group. So we assume if it's a 2% rate by age 8, it's not 2% at age 3, because some of those kids just aren't declaring themselves as autistic at that point. So we graded our sort of estimates based on those estimates, so we could just adjust our denominators appropriately. And so what we found is we think we probably ascertained close to 40% of the population of kids with autism in the state of Rhode Island, and in the younger groups even more than that, which we think is pretty remarkable in terms of depth of sampling for just under 6 years of effort. And that allowed us to publish some papers. And so these are just a sample of a few of the papers that were published out of the Reichart database. We have another one coming out next month that was on young adults with autism. That was where we co-enrolled people into the Reichart study, and another study of facial affect presentation. And I won't talk too much about that other than to say that it'll come out soon. And so this really allowed us to engage with the community, and especially in the top one here, some of the individuals and stakeholders were, because they were part of the research project, were included in that publication as well. And we did some other really fun and interesting things with the community in broad ways as well. So we had various workshops that sort of were givebacks to the community, as well as recruitment events. One that we repeated several times was really bringing together clinicians, attorneys, and special educators, and thinking about how do clinicians write up research reports and collaborate instead of battle with school systems. And that was a really interesting panel to do. And we did that several times, actually. These are two community-related events that just had the prettiest pictures associated with them, which is why I was showing the good stories. So we had several rounds of a professionally curated art show where the art was produced by kids and adults with autism. This happened at the Rhode Island Museum of Work and Culture, so it was also partnering with a community organization which donated their gallery space for us. So we got to have a real live opening. We had a professional artist who curated the show, which made a big difference. We organized it around a theme, and then there was a formal opening with, juice and cheese and stuff like that. And then it remained up in the gallery for 3 months so that visitors to the museum could go through and really see it as an exhibit. And some of the artwork was really beautiful, actually. This was a wood cutting. I have a wood cutting at home, which is awesome. So some of it was for sale by the artists as well. Another one, which brought us out of Rhode Island and down to New York, was a collaboration with the Fashion Institute of Technology in New York, which is part of the CUNY system. And we discovered they had a toy design department. And because part of this work was funded and supported by the Hassenfeld Institute, which is the Hasbro toy family company, the FIT toy design company called Alan Hassenfeld, who's the sort of the patriarch of that family, said, "Do you know anybody in New York who knows anything about autism? We want to do a capstone project for seniors on developing toys for autism and kids with disabilities." And Alan said, "I don't know anybody in New York, but I know Rhode Island people." And so he knows plenty of people in New York, but he was supporting us, which was great. So for the past 6 years or so, we've been at first physically and now virtually going down to FIT and doing some didactics for the students and helping guide them through the thought process of developing toys for special needs children, especially autism. They do field observations at schools in New York that we helped connect them to, and then they produce these they're real artists. So they produce these beautiful drawings and then even scale models of these toys. And that's just a really fun, feel-good sort of community engagement piece. And so there's just all sorts of creative things you can do, I think, with the community. They're very strength-based and fun. And then in Missouri, we have some really exciting things happening at the Thompson Center for Autism and Neurodevelopment in Missouri. We have really strong community engagement supported by state grants that fund a variety of training opportunities for families, parents of kids with autism, individuals with autism, educators and community providers, some of which are done in the field, some of which happen in our building. We have a new building that is slated to open in the winter to early spring of 2026. And this was, we're really proud of this. And I helped spearhead some really important things in this building. So we designed it from the ground up to be really friendly and inviting and inclusive of the broad range of individuals that we serve, and one that supports from the ground up collaboration. And so this is the artist rendering of the structure. But in our clinic area, we have psychology and developmental pediatrics really situated adjacent to one another with fluid ways of interacting in areas that I guess pediatrics we call swamp areas. So areas where clinicians sort of gather to sort of launch clinical care, and that really supports collaborations for patients in the course of the clinical day. We have an ABA program that has classroom spaces, and that's wonderful to have ABA in the same building as developmental needs, psychology, speech, language, OT, because it fosters collaboration between ABA providers and these other disciplines, which are often in reality in many communities so distinct and at loggerheads. And this really offers really positive collaboration, which is awesome. We also worked carefully with our state contacts in Jefferson City, the state capital, patient groups, other clinical colleagues around the state to identify where there are gaps in services. And one of the gaps we identified was the need to serve high acuity patients, individuals with autism who have, for example, high self-injurious behavior or aggression, behaviors that place themselves or others at risk, and that we don't want to end up in an inpatient hospitalization. And so we're just not, right now we have a very small, serve 2 or 3 kids at a time severe behavior clinic. We're now building that out to be a partial hospital program that allows for multidisciplinary care with a day hospital rate. So it's financially viable to serve greater numbers of children, and designing a whole section of the building that is sort of secure and designed for that model. And so that allows us to think about, what is a center like this? And the same, I know you guys think about this at Mailman Center as well. How do we think about doing things that don't repeat or replicate what can already be done in the community, but that sort of fit a need that is in a way a tertiary care need, and that builds on the expertise that an academic medical center can provide. So that's been really fun to think about. The steel structure is up, and it's so far in time. And so I just want to give you some sense about how we think about various ways of interacting with the community. And I'll end with that and just thank our funders. And although we're a little older over time, I apologize about that, but if people want to ask questions, I'm here. So sure. Thank you.
Great. Thank you very much. To our virtual audience, I forgot to mention, if anybody wants to get CE credits, let me know. Is there anybody out there who needs CEs or wants to get CE for this, for psychology or social work? Or...
I would imagine that Rosalind will probably put the link in the chat. I guess.
I don't know if she put it in the chat or not, but we do have a QR code that I'm not hearing anybody from the group. Anybody here who wants to. Well, I had one thing I was thinking about,
yeah,
as you were discussing this, and even thinking about the internal lifestyle study where I think you said there were like 1,600 kids or something like that, but only 12 that were confirmed diagnoses. Mm-hmm. So that's clearly, and that was in the 90s, that was clearly the more extreme cases of autistic disorder, and not ASD or spectrum type disorders. So most of the work that you're describing, though, is with the more severe class of those kids who really would be, more autistic disorder as opposed to spectrum disorders, much milder cases, right?
Yes and no. So I think for maternal lifestyle study, I think that's true. I think if we were to repeat that now, we might find some more kids who would have different variants in presentations of autism. I agree with you, Al.
Yeah.
And that's interesting. One implication for that is, would that increase or decrease our sort of power to find signal early on, right?
That's kind of where I was going with it, because in your vocalization and the crying work that you're
Mhm.
doing, and that's more recent.
Mhm.
So those are kids, well, of course, you haven't followed them up to the, to be able to define if they really meet criteria at age 5 or 6 or whatever. I think you said you're only up to about age 2 to 4.
Yeah, we're 2 to 3 now, so we're in the midst. We're doing formal diagnostic outcomes on those individuals at 2 to 3 years of age. So far, we have 16 kids from the study who have declared themselves so there's a best estimate clinical diagnosis. We were waiting on some more cases to come in before we start to crack into those data. Because we're observing those kids in a different way than just waiting for them to be referred, it's possible that they may also include sort of more mild variants, if you will, because it's not, we're making sure they all get the MCHAT, et cetera. On the other hand, if they have enough of a representation to have a clear diagnosis at that age, that might be a little more prototypical and may offer us some comparability to the MLS data. Ultimately, we need your comment sort of, I think, raises a really important challenge for infancy work, which is how do we get sufficient numbers of kids at these outcomes that allows us to subgroup appropriately and look at different types of outcomes. And that's a sample size challenge.
You're going to need big samples.
Big samples, exactly.
Absolutely do that. And it made me think too about the crying, because I was reflecting back on my own kids crying, and I know they cry for a lot of different reasons, and there's different sounds to those cries. And it made me just wonder about, in terms of your methodology, you first talked about a standardized way to get them to cry something on their heel, right? But now your work is more naturalistic, and it's like you can get them to all different kinds of cries. And I'm just wondering, within babies, I think there's probably a lot of variability of the type of cry. That's what my recollection is about my own kids.
Yep.
But what are you finding, when you really begin to look at that?
When we look at our data,
is that as good as the naturalistic, as good as the standardized, or is this just a methodological challenge?
It's a methodological challenge. Is it as good? I don't know yet. What we can do to try to problem solve on this is use a couple of different sort of indicators. One is we do have parent surveys that get a sense of why the babies are crying, and we can subgroup some of those cries based on that. And so there may be sort of setting. Parents are often pretty good at knowing why their babies are crying.
Oh, he's got a wet diaper.
Yeah.
Oh, he's hungry.
Yeah.
Oh.
So we can, and I think parents are pretty good at that. In fact, sometimes we have people from industries say, "Oh, I want to get a cry recorder. We want to use our technology to help parents interpret their cries." And no, we don't want to do that, because we don't want to get in the way of sort of what I think is intuitive parenting. Parents know this well. So we can use some of those data. The other thing we can do is to look at how prototypical looking the cry is. And so we do find variation in the cries that we've looked at so far. And some are prototypical sort of reduplicated full crying utterances. And others are clear cries, but they're on the fussier side and they're less sort of rhythmic. And so we can divide the cries up in that way and first describe the cries, and to do so carefully so that we're not biasing our analyses, but to think through sort of from a data-driven point of view, what is a prototypical crying episode, and whether that is maybe a more standardized, powerful way of looking at that.
So, but you're really getting to whether or not the cry can serve as a predictor for development of autism, right? As an very early predictor.
Or sorry to interrupt, Alan, but predictor of developmental outcomes. I actually don't. Yeah, I'm not. The way we designed our aims for this grant was not to presume that cry alone would have the sufficient sensitivity and specificity to be a standalone screener. I don't think that's realistic. But when combined longitudinally with other indicators that we collect over the course of the first year of life, there may be some algorithms that we can applies so that by the time we get to 9 to 12 months, we have a more refined idea of who's at elevated likelihood. Or in order to sort of circle back and refine algorithms, that probably might be a way to sort of refine the machine learning that we might use on later attained signal in the 9 to 12 month period to refine that as well. And it may be that we end up predicting autism pretty specifically that way, but it may also be that we end up predicting developmental delay inclusive, but not exclusive to autism. And we think that's valuable as well, as long as we are clear about what we are predicting, and that would really influence, those findings would influence how we talk about that with families. And what,
You could see you could probably have an AI sort of application that could give you a snippet of a cry and do all that analysis that you were just describing. But it must be qualitatively different type of cry, a different sound, right? Than, that would indicate risk for some kind of developmental problems down the road.
yeah, there may be, especially when you get to, and so there's some things that might, I would imagine that there are going to be some conditions that are going to obscure some of the signal associated with autism. Things that have to do with sort of lung disease, things like that. We have to be sensitive to those things. We're going to have to sort of be very cautious about the development of these algorithms ultimately.
Yeah, I was just gonna ask, how's it going with, people, well, they have things like Alexas or use Siri, but, so it's as soon as you're like this idea of recording within the home and you're using an EMA process where you don't know like what day you're recording, what has been the actual success rate of like, hey, you're up for recording your baby crying today in terms of actually getting them to record?
At first it was harder. We were sort of fixing this plane as it was flying.
Yes.
So if you look at the rate of acquisition of cry in the first several months of our efforts to use this method, it was not as good as we wanted it to be. It's much better now, and I don't know the percentage offhand, but I think in later parts of our recruitment, it's probably 70 to 80% rate of acquisition of clients for babies we're recruiting, whereas early on it's probably 50 to 60%. So that was a challenge, and going to impact our research. There's no way around it.
What do you think changed that all of a sudden, like, did you guys change your, like?
Some of the way we communicated it to the families, some of the ways we tweak the EMA to make some of those steps a little more easy and straightforward for the patients. When we introduced downloading the application on the phone and the amount of help we gave to the parents to do that, what we found is if parents download the tool and sign up, we get the cry. Okay. It's that initial step we find is the rate limiting factor. Because once they get it, it's on their phone. They're pretty fluid phones. They get pop-ups and we can also call and remind patients at that point.
And how messy are the audio recordings in the home? I imagine you get background noise, you get parents talking, and
they're messy.
Even if like, which I mean, it's but on their mobile device it's scalable, whereas like the other things would not be scalable. So
no, it's messy. So we have a pretty careful process of training staff to listen to each recording that comes in and make a series of determination. One is, was there a cry? Sometimes there's no cry. If there's a cry, is there any part of this recording that's suitable for acoustic analysis that's free of background noise? Sometimes the whole thing is. Sometimes only part of it is, and then we need to excise the part that's appropriate. And so that's a curation process. When we do that, we train people to reliability on how many clips of recordings they're pulling from the source recording and how long the total sample of recording is that's subjected to analysis. So we're at quite a good reliability rate for making a determination of yes or no, is the sample visible, is there something here? And quite a good percent agreement on the number of clips that are generated and strong inter-class correlation for the length of the recording that are done. So that took a lot of effort to do, a lot of training.
All right, thank you. very much.
Thank you.
Very good.